Welcome, everyone. Can you hear me? Just give a thumbs up in the chat. Good. Sorry for the slight delay. We'll be kicking off now. Welcome and well done for tuning in on a Saturday morning. I hope everyone's preparation is going well. My name is Shoaib and I'm the course organizer for BitePACES. And as a lot of you may well be aware, we host these regular webinars throughout the next couple of weeks and have been doing so over the last few months. I know everyone always asks for the recordings. I will try my best to get them uploaded to YouTube in the next week or so. So without further ado, just a bit about the courses as usual before we kick off. We will be holding our January and February courses for the next diet. So please do check those out on our website. The QR code for the website there is in the top right. And please do join our WhatsApp group because that's where we post about our webinar schedule. And you can ask any questions on there that you may have related to PACES. In terms of the courses that we offer, we have a 1-day course and a 4-day course. And the idea is you see as many patients as possible in small groups of no more than 2, which is where I think we're unique. And some of the cases we've had on the previous courses, were amazing. We had things like Eisenmenger syndrome and double lung transplants. So please do check out the courses. We've been fortunate enough to get some very good feedback. And for those of you tuning into the webinar, you're entitled to a discount. But yeah, I mean, the feedback kind of speaks for itself. And please do check us out. Next webinars are listed here. So we'll be doing some stuff obviously today on cardiology, respiratory, some tips and tricks, communication. We did a clinical consultation webinar a few days ago, and I'll try to get another neurology webinar sorted out at some point. So please do keep an eye out. And without further ado, I'm going to hand over to Chern, who's one of our faculty. He's taught on our previous course. He's a cardiologist and a very good teacher, and I'm sure you're in very good hands. So Chern, without further ado, I'll hand the stage over to you.
Cool, thank you. Cool. Slides. All right. Just to check, just throw it in the group. Can everybody see my slides? Okay, perfect. Right, let's start then. Sorry, the delays from my side of things. I didn't register, so. Good morning on a Saturday. I'm sorry to drag you out of bed on a nice autumn morning. What we are going to do today is to talk you through how you're going to approach your cardiology station. It's actually more useful now that I'm doing this, having sort of been faculty of the actual sort of PACES stations on the last diet for BitePACES. So I'm just gonna sort of give you my experience of managing one of those stations at that time, and how can you sort of approach your stations in a very systematic order. My name is Chern. I'm one of the new cardiology ST4s at Princess Royal Hospital. And again, now that I've got a little bit more experience, hopefully it comes through in this presentation as well. Okay, so without further ado, learning objectives for today. I'm going to hopefully show you that by the end of today, you can demonstrate a theoretical understanding of how to perform a cardiovascular examination. Hopefully, by the end of the day, you can elicit ability to interpret physical findings and create a suitable differential diagnosis. So after we've done the lecture, at least if we can do 2 or 3 case scenarios, that would be great. And please let me know, because I can't download any sort of sound clips. So I'm using YouTube videos. If you can't hear it, I do apologize at the start. And then at the end, we'll formulate an appropriate management plan for the patients. Okay. So, agenda for today, we'll first discuss your station format. We'll then discuss how to approach the patient at the bedside, and then we're going to formulate the management plan for that patient. All right. There's not going to be a lot of words. I'm trying to keep as interactive as possible. So throw all your thoughts, your answers into the chat. Any questions, I'm happy to be interrupted at appropriate points of the lecture. So just to run through your PACES format. So for station 3, you are going to, one of the stations in station 3 is your 10-minute cardiovascular station. In 6 minutes, you are expected to demonstrate an understanding and perform a cardiovascular exam, elicit your ability to interpret your physical findings in your head, okay, when you're seeing the patient. And in 4 minutes, you're in the other 4 minutes of your exam, you have to come up with a differential diagnosis based on your examination and physical findings, come up with a management plan. And throughout those 10 minutes, you need to show that you treat the patient sensitively and respectfully. So always be what I mean is that you always need to be mindful as to their positioning, as particularly if they're in pain, they're breathless. And that's not just for the cardiovascular exam. That's for every single station in your PACES exam. You have to make sure that they're comfortable, that they feel safe, and they're exposed in a dignified manner as well, okay? Because we are doing sort of physical examinations on these patients, so be very mindful, especially on female patients. So this is your format, as we've discussed: 10 minutes, 6 minutes to examine, 4 minutes to question. And an example of a written instruction is this. This 70-year-old man has chest pain on exertion. Please examine his cardiovascular system. That's it, okay? There's nothing else in that. There's not going to be anything else in that scenario to give you any hints as to what this condition could be. Okay, so it's really a test of your ability to pick up physical signs. So when you come into your station, and so say you're switching stations, or even before you start a station, you're outside the station, what do you have to do? Just throw it in the chat. Before you start the station, when you're outside. Yep, hand sanitizer. Yep, good. Anything else? So so you're right. So if they give you a hand sanitizer, if they give you gloves and apron, always make sure that you clean your hands depending on, always make sure your hands are clean for every station. But also when I did my examination in COVID time, so I had to put gloves and aprons on. So if they do have it there, your option is there to use it as well. Think about likely diagnosis. I wouldn't so that's good, but I wouldn't go and pin yourself down to limit yourself to those 3 or 4 things. Always keep your mind open, okay? What I would suggest is that, yes, approach to the station, think about your approach. The first thing, and a lot of people sort of make a mistake, is they're so keen to start the station that they don't read the question. Thank you, Harrison. Yes, read the question. That's the most important thing, because you just need to know what examination you're doing, especially if you're more on the nervous type. So you're feeling particularly nervous on that day. So you don't want to go into a cardiovascular station to do an abdominal examination. All right? Always read your question. Now, when you approach the patient, can somebody just tell me, how do you approach your patient when you go in? When you head into the station, go for it. Don't need to raise your hand. Just put what you think. So you go in, what do you do first? Yep, very good. Yes, absolutely. Introductions first. Perfect. Yep. So very good. So at the very start, you don't go in and just start examining the patient. The first thing that you do is you examine the patient, look on the walls for any cues as to what your question could be as well, because sometimes they'll put another scenario on the wall in your station. Um, and yes, always make sure that the patient is comfortable, how you're going to move them, that sort of stuff. You then do your bedside overview, like what Zainab has said. So look for your surroundings, look at the patient, and then you check hand. You sort of go up, do through the motions, hand, neck, face, and mouth. And for your cardiovascular exam, you don't have to percuss. All you have to do is inspect, palpate, and auscultate. Last but not least, always make sure that you have a minute to examine the abdomen, and always examine the legs as well. And I'll talk in future slides as to why those are important. So before touching the patient, so we've done introductions. What do you have to do apart from, yeah, so exactly right. So look for surroundings. So wash your hands, gloves, yep, ask about pain. So yeah, permission, introductions as well. The other thing, so that picture at the end, the reason why I've put that picture is because you always want to clarify about exposure, okay? So regardless whether they're male, they're female, or whatever gender that they are, always make sure that you ask that you can expose them appropriately, okay? So because in the cardiac examination, you need to make sure that you're able to identify those scars. You need to get to their chest to listen to those murmurs. So for male, relatively easier because they just need to take the top off as long as they're happy with that. For females, always check with them that they're okay with you exposing them and taking off their bras at the appropriate time. And once you're done examining the chest, that they can cover back up, that they can cover themselves when you're examining the abdomen and the legs. Okay? And the slickness of doing that will only come when you have to do it in real life, when you're examining your patients on the bedside, when you're doing your practice in hospital. So bedside examination. Now, everybody's always has already chipped in with looking at the bedside. Okay, so always just check: are they young, middle-aged, they're old, they're sex? Okay, are they in pain? Are they are they comfortable? Okay, other things that you're gonna look out for is cyanosis, whether they're acyanotic. So how just in case you get an ACHD patient, you want to see whether they have a blue tinge to their lips, blue tinge to their nails if you can see any deformities if they've already exposed themselves. So whether that's length of their arms, the shape of their chest, all right, and scars. What sort of scars are we looking at that we particularly pay attention to in a cardiovascular exam? Yep, midline stenotomy. Anyone else? Any other scars? Vein harvest. Yep, very good. Pacemakers. Yep, very good. Where can you get pacemaker scars? Yep, pectoral. Yep, which side? Left or right? Yep, very good. You also get subcut ICDs in the left axilla as well. So always just when you do your bedside chat without even touching the patient, always make sure that you just sort of look at their tables, look at the patient, and always look not only at the front but always look on the sides and make sure there's no scars, just in case you do get a patient who has a subcut ICD. ACH. Some patients who've either had device infections, you could either you could sometimes also get pacemakers on the abdominal wall as well. So just be mindful if you do see any sort of like a rectangular, not rectangular, like a round mass on the abdominal wall. So just be mindful of that. So some of your ACHD patients, some of your patients who've had device infections, that's the time where we tend to implant either on the right side because they need the ones typically on the left sort of extracted, okay, or they're infected. Listen. Now, most murmurs, you probably have to auscultate with your stethoscope. Any ones in particular where you can listen, that are particularly audible at the end of the bed? Yeah, metallic valves, easy. You hear a metallic valve, you know you're one step closer to the answer. Okay, good. Obviously, look at their table, look at medications. Do they have their GTN sprays? Do they have their aspirin laid out on the table? Okay, and of course, ECGs if they're available. All right. Right, let's see whether this works. Can you hear that? I know we're at the advert, but can you hear this? No.
Let's go through a few types of mechanical heart valves. There's a valve called a Starr-Edwards valve. And this is a ball in a cage. And as the ball, identify what type of valve they have. So a click will replace the first heart sound for a metallic mitral valve. So let's hear an example of that. Click will replace the second heart sound for a metallic aortic valve, and let's hear an example of that.
We're happy with that. What's the so when you hear a metallic valve, always sort of pay attention to when you hear the click. So as what the video demonstrated, if the metallic click happens on S1, S2, where it's your closure of your mitral and tricuspid valve, you know it's very like it's you know that your prosthetic valve, the metallic valve, is a mitral valve. If it is on S2, it will be a metallic aortic valve. Are we happy with that? I think with valves, you just literally have to have really good headphones on and just sit there for 10 minutes and just sort of get into your head. It's one of those things that you want to do sort of a night or two before the exam and just get into your head what a metallic valve sounds like. Okay. Sort of, I mean, I don't say just wait until the last 2 days to listen to it, but you know, if it's one of those two things, one of those things that you want to sort of study last minute and make sure you don't forget, this is one of them. Is literally sit down for half an hour to listen to a murmur. Are we happy to move on? Or any questions on this side? Yep, good. So nails, right? Let's start. I'll do less talking now. What's number one? Top left corner. Clubbing. What cardiac conditions can cause finger clubbing? Yep, cyanotic heart disease. So tetralogy of Fallot. Eisenmenger. Yep, very good. Another one. Any other cardiac conditions that can cause clubbing? Infective endocarditis. You're right. It's very rare though. Very rare. I don't think I've ever seen a endocarditis patient with a finger clubbing. But yeah, yes, atrial myxoma, you can. Right, what's the next one? So we're going clockwise. Yeah, shiny hands. Why is it shiny? No, yep, sweaty. So yep, it's sweaty. So what conditions? Now, I'll give you a hint. It's not cardiac, but it can cause a cardiac complication. What condition can make you sweaty? So sweaty palms. Yep, thyroid, AF. Yep. So you see someone with sweaty palms, and they've got an irregular heartbeat, irregular pulse. You know, you're one step closer to this patient being hypothyroid. May not be in your cardiac station, but it could be one of your station 5 stations. Fine. What's the one in the blue box? Sorry, blue, red. Sorry, I don't have colorblind. It's red. Long fingers. Yep. Sclerodactyly. So what condition can cause that? Yep, Marfan's. Yep, very good. Yeah, it's arachnodactyly. I was just having a think. It's definitely not sclerodactyly. Yeah, arachnodactyly. Thank you, Rosemary. Fine. What's the next one? The other nail sign. Yeah, very good. Yeah, Marfan, homocystinuria, Lois Dietz. Yeah, very good. Going down the aortic route now. What's that fingernail? Splinters. Yep, very good. Splinter hemorrhages. Okay. Then moving on to the left, and then we'll just make our way down to the end. Go on. What's this one on the left here? If you see that. No. Tar staining. Yep, good. This one. Quinkies. Yeah, they're just acyanotic. Yeah, this is just another sign to point towards acyanosis. So, um, clubbing. Yeah, good shout. It could be. But yeah, you might have some clubbing actually on that finger, actually on the second digit. Yeah, good shout. And yeah, they're cyanotic as well. I think that's where I was pointing. But yeah, cyanosis, yeah, point you towards any sort of structural heart disease like a VSD, ASD, okay, that then be turned into an Eisenmenger's, okay, or if they've got, a cyanotic heart disease, right? Janeway and Osler's, what's the difference? Okay, which one is painful? Yeah, Oslo is painful. Yep, very good. And at the end, what's this pink picture pointing towards? Track marks. Perfect. We've got patients with these track marks. Yeah, track marks. They've got a fever. They've got a murmur. We're pointing towards endocarditis. So very good. Right, next one. Okay, next thing you want to do after you've examined the hands and the nails, you then move up. Now, I mentioned, so you obviously want to check your pulse first. Are they regular? Are they irregular? And you stand there with your fob watch and just start calculating the rate as well. With patients where you have identified an irregular pulse, you do have to sort of you do have to sort of measure it a little bit longer compared to your regular pulse there. Then you lift your arm up to check for any water hammer pulse, always making sure that, always check with the patient first whether they have any shoulder pain. All right, so in patient, just obviously be mindful if patients have had surgery or surgery or arthritis in that shoulder that you're going to raise their arm on. Otherwise, you might not be able to, but just tell the examiner that you're going to do it. And then you're going to mention that you're going to check their brachial pulse and their blood pressure. You don't actually have to do it in the examination itself. Okay, another picture round, face and eyes. So start from the top left, ending with bottom right. So let's start. Yep, malar flush. Yes, what conditions can give you malar flush? Yep, mitral stenosis. Very good. How about these ones? Exactly. Very good. Yep, amiodarone, slate gray. Perfect. Okay. This one. Yep. What cardiac conditions can occur with Down syndrome? Yes, you're right. So yeah, AVSDs tend to be AVSDs. So your endocardial cushion defects are tend to be associated with Down syndrome. So VSDs, ASDs. Okay. This one here. Yep. Yep. Very good. Ehlers-Danlos with their stretchy skin. Okay. If you hear a diastolic murmur, I hope that they don't have a diastolic murmur in the exam, but yeah, AR, and that's pointing towards, if you get Ehlers-Danlos with an AR murmur, yeah, yeah, definitely they're probably dissecting. So you would hope that that doesn't come out in the exam, but just in case, they might actually need to go to A&E. Good. This one here. Yep, Graves, again, very good. This one here. Not so much blue, just focus on the eyelid. Pallor, very good. Okay, someone with iron deficiency, always check, yeah. So always just check patients with iron deficiency anemia can coexist with patients who have ischemic heart disease or aortic stenosis, all right? This one, xanthelasma, very good. Okay. Okay, neck. So neck, so once you've done your face, move down. So the next level that you move down is your neck. Okay. Now, to look at the neck, you want to obviously assess your JVP and also palpate your carotid. Okay, so always palpate your carotid. Make sure you can feel a pulse, especially if they're peripherally shut down or you can't really feel a pulse peripherally. Always check your carotids. You can auscultate at that point as well. But the next thing is everybody wants to look for is that JVP. Are they fluid overloaded or not, or do they have heart failure? Okay, so if they don't have an A wave, either they have atrial fibrillation or they just don't have a raised intrathoracic pressure. Raised JVP but non-pulsatile, you always make sure you always check in patients that you're suspecting SVC obstruction, okay? Or if they've got large V waves, so if they're really sort of tracking upwards, it might imply that they have heart failure or severe tricuspid regurg that you have to pay attention to. What do you do if you cannot see that JVP? Hepatojugular, exactly. please always make sure that you warm up your hands and ask the patient that can you feel their abdomen or not, because you don't want to just pounce in and start pushing against the liver. Okay, always make sure that they do it as in your I think on the last sort of inpatient PACES course, the patient that I was with, he was having a lot of abdominal pain at that point, just by virtue of people trying to elicit hepatojugular reflex. So always check in with your patient to see whether they are happy for you to do it, especially if you're coming towards the end of the day. All right. Good. Mouth. Another picture round. Good. So I'm not going to say this because that's just a clean mouth. How about this one? This one here. Yeah, dental caries, poor dentition. In fact, yeah, Harrison, you took the words out of my mouth. So always pay attention. Sometimes you will get patients who have poor dental hygiene, and they do increase your risk for strepmitis, infective endocarditis. All right, especially if you see someone with poor dental hygiene, you hear a murmur, I think you're one step closer towards the answer. We've talked about cyanosis a lot, so that's what the cyanotic lip look like. This one. Angular stomatitis. Yes, angular colitis. Very good. Okay, patients with iron deficiency anemia. Okay, chest is another picture round. Very good. So, everybody has mentioned that median sternotomy scar before. So any of I think what patients would have, what sort of cardiac patient would have had a median sternotomy? Cabbage, anything else? Yep, valve replacements, yes. What else? So yeah, so ischemic heart disease, valve replacements, yep, root repairs. Transplants, yes, transplants, especially if, I guess if you see patients with, I don't know, maybe like SCC on their skin and stuff, yeah. Congenital heart surgery, that's the other one. Yep, very good. Okay, how about this picture? What's that pointing towards? Yep, midline sternotomy and a pacemaker. And this is your subcut ICD. So it will be so it tends to be patients who are fit, okay, your younger patients but physically fit, and it will be in the mid-axillary line. That will be your patients who would qualify for subcut ICD. So always just make sure when you're examining that you're looking at that mid-axilla. All right, this one. No, it wouldn't be a pericardiocentesis. That will tend to be at your ciphisternal joint. Yep, Hickman lines. Yes. So in cardiac patients, it would be patients who have very poor circulation. So maybe your ACHD, your endocarditis patients. But it tends to happen in your oncology patient. You tend to see in your oncology patients, okay? Sometimes your renal patients as well, they tend to put a central line rather than a fistula. Good. This one. Not rickets. Yep, pectus. Exactly. So pectus excavatum. Any cardiac conditions associated with pectus? Yeah, no. Don't have to apologize. Yes. Connective tissue disease. Yeah, it can be associated with Marfan's, Ehlers-Danlos loss. If you do hear a mid-systolic click murmur, yes, MVP, so mitral valve prolapse. Okay. Good. Palpation. Right. So when it comes to palpating your patients, the three things that you're going to palpate: apex for that apex beat. You also want to palpate for heaves and thrills, okay? And to palpate the apex beat, can anybody tell me how you're going to palpate the apex beat? What sort of positions that you want the patient to be in? Yep, supine and then left lateral if you can't palpate it, okay? So fifth intercostal space. Just be aware if you can't feel a beat, always just check the right side and make sure, just in case if this patient's got dextrocardia, okay? Sometimes you do have to move down a little bit, all right? Because there are certain conditions where your patient's apex might be displaced. So patients with heart failure, cardiomegaly, mitral regurg, those are aortic regurg as well. Their apexes can be displaced. Okay, or if they're impalpable, so if they've got COPD, so there's a lot of lung that's sort of stopping you from being able to feel that apex beat, if they're obese, okay, or if they've got large effusions. All right, so those are the other patients that you have to be mindful about. So heaves and thrills. So thrill is easy, so it's just a palpable murmur, okay? And you want to just feel on the chest, so sternum, okay, on the right, and then on the left as well. Just feel for the thrills, okay? And then whilst you're palpating for the apex, you want to find if there's any sort of apical heave, okay? Any forceful ventricular contraction. So at the left sternal edge, okay? And also if in the apex, especially if they've got left ventricular hypertrophy. Okay, auscultate, right. Be mindful that in order to identify a murmur depending on their cardiac cycle, you always have to palpate it alongside the pulse. All right. So what you need to do when you're practicing is to develop the slickness and the dexterity to be able to listen to auscultate the lung with your the heart with your stethoscope, but also palpate for the carotid at the same time. So you want to know, do you hear the murmur at S1 or S2? Okay. If you feel it at S1, that murmur would most likely be a mitral tricuspid closure, S2, aortic and pulmonary. What cardiac condition is the most common? Oh, sorry, what valvular abnormality is the most common in this country? Yeah, aortic stenosis. Okay, aortic stenosis. Can you describe an aortic stenosis? An aortic stenosis murmur. Yep, ESM, radiating to carotids. Anything else? Especially if they're severe. Yep, soft S2 or absent. Okay, anything else? Yep, increase on expiration. Yes, and a slow rising pulse, and if they've got LVH. Very good. So yes, always go through the motion. So start aortic, pulmonary, tricuspid, and the mitral. Okay, and take to notice, do they get louder on inspiration, which will point towards more of a right heart murmur, or whereas those on the left side tends to get louder with expiration. Okay, do your Valsalva maneuvers as well. Get them to hold their breath on expiration. Which cardiac condition tends to get louder with Valsalva? Yep, very good. Yep, HOCM especially. Mitral valve prolapses as well. Good. You want to do it with, you want to listen to most of your murmurs with a diaphragm, okay? Probably the only murmur that you need to use the bell for is when you're at the apex to listen to a mitral stenosis murmur. And the reason is because the mitral stenosis murmur, and you only use your bell for it, is because it's a low flow murmur, okay? Do it in the left lateral position. That's the only time where you actually need to use your bell. You don't need to use your bell in all the cardiac, in all the other valves. To listen for aortic regurg, get them to lean forward, and breath following exhalation. That's the time where you do your Valsalva as well. Okay, and then always remember to listen to the lungs. Some people unfortunately forget to listen to the lungs. Okay, and when you're listening to the lungs, you will have time because your cardiac examination is much shorter and much less steps to do than a respiratory exam. Always listen from apex down to the lungs, down to the bases. Because yeah, great, you can listen to crackles at the bases, but always just check whether do they have crackles all the way to the top. Okay, or if you feel like, okay, the bases ain't gonna give you, if the bases are not so audible, always just check at the top as well. All right, you do have a full set of lungs, not just the bases. And at the end, once you've listened to the heart, always listen to that carotid bruit as well. Okay, once you've done with your chest, move down. Okay, move down. You're gonna find the abdomen. Anyone can pick up what this sign is? Yeah, ascites. Yes, very good. Anyone with sort of decompensated heart failure, always look for ascites. Yeah, pulsatile liver and the intracuspid regurg can also do that as well, especially if they've got really congestive cardiac failure. Everything gets pushed backwards, so you get patients with ascites, patients with large amounts of pitting edema. One thing I didn't mention as well. After you've auscultated the lungs, whilst you're at the back, always just assess their sacrum and to see if they've got sacral edema. Okay, if they've got sacral edema and you've seen, swelling in their legs or swelling in their abdomen, it will point you towards a congestive state. Good, legs, right. Picture number one, the answer is there. Chronic venous insufficiency, always look for that. Assess their legs for that hemosiderin deposit. All right. This one, what's this? Which vein? I know it sounds silly, but what vein is it? Yeah, it's a venous vein. Okay. Always sort of look up, look higher up as well. So the old times, you get a large saphenous vein graph where they dissect all the way down to the malleolus. Okay. Now that technology is more advanced, they tend to do it endovascularly, so they might actually just make a slit at the knee as well, at the knee, on the medial aspect of the knee as well. So always just check sort of higher up on the medial aspect of your thigh to see whether the scar is there. Okay, I think it's less likely that people dissect all the way down, because people can harvest the vein endovascularly. This one. Yep, pitting edema, very good. So investigations. To do better, so you've done your 6 minutes now. You have 4 minutes. This is a time where you're gonna spend 30 minutes, not 30 minutes, 30 seconds in your head as to what your list of differentials could be. So if you get a 70-year-old man with chest pain, always think about, okay, what are my list of differentials? Oh, I heard a ejection systolic murmur. That would be my top. What's my second one? What's my third one? Okay. In your investigations, always think, what can I do at the bedside? So ABGs, ECGs, basic observations. What bloods you want to do that will be relevant in these patients. So lipid profiles, HbA1c, always do that for patients that are suffering ischemic heart disease. Okay, iron levels in their heart failure, especially if they've got heart failure, TROPS, BNPs, and the usual stuff. Okay, obviously CRP if you're suspecting infection. And then think about what sort of imaging you want to do as well. Start with the basics, so x-rays. You cannot go wrong in a cardiac examination by saying that you're going to do an echocardiogram as well. And then of course, anything more than that, if you get a murmur, if you're suspecting ischemic heart disease, always think about coronary angiograms. Good. Management, like any other thing, conservative, medical, surgical. All right. So I think we have 10 minutes. So let's try and work through at least 2 cases. Okay. And then that should take us to, 10 past 11 so it will be an hour from where we started. And then you guys can spend the rest of the day so consolidating your knowledge. So we'll start with the first case. 75-year-old man presented with chest pain. Please perform a cardiovascular exam. Okay. You do your examination. Everything is normal. Okay. Everything is normal. No heaves, no thrills. And all you see, all you hear,
there will be also what we call you'll hear a systolic murmur. It causes a murmur that gets
okay. So what would be your diagnosis? Sorry, I know it sounds silly, but what would be your differential diagnosis here? So you hear that murmur, second right intercostal space. What would can someone just put you hear that murmur, what's your list of differentials, or what's your diagnosis? Yep, AS. Elderly person coming with chest pain as well. Is there anything else that you would put in your differential? So I wouldn't put aortic sclerosis as a differential because sclerosis just means thickening of the valves. Yeah, so it's you get that as you get older. It's not a pathology that will kill you. So I wouldn't put that as a differential. So stenosis, yes, yeah, coronary artery disease, I would put that in. Okay. So aortic stenosis, coronary artery disease. Yep, endocarditis, but you have to make sure you can put that as a differential, but you have to back up as to why this patient is unlikely to have endocarditis or have endocarditis. Okay, so whatever that you back up in your put in your differential, always back up as to why this is more likely or less likely. Okay, so aortic stenosis in this country, what's the most likely cause of aortic stenosis? Calcification. What's number 2? Yeah, bicuspid. Yeah. So those are your 2 most common causes. You tend to find these patients who have an ejection systolic murmur. If they're severe enough, they do radiate to the carotid. And like when we mentioned before, features of severe AS, get that in your head. Slow rising pulse, soft or absent attitude, narrow pulse pressure. Okay? So yeah, bedside, get ECG, get bloods, make sure you check the lipid profiles as well. And before you think, and always get a TTE. Always mention that you're going to do some sort of coronary vessel, epicardial coronary vessel imaging, whether it's an invasive angiogram, if they have clear signs of angina, or at least a CTCA, if not a TAVI protocol CT. If you know that patient is heading down the TAVI route, okay? Because you want to see if they have enough coronary artery disease to warrant a bypass simultaneously. Okay, so medically optimize them. Try and avoid using ACE inhibitors if they're not, or increase their ACE inhibitors if they're not on already. If they've got coronary artery disease, always make sure that they're on aspirin and statin. Optimize all the cardiovascular risk factors. And depending on your angiogram and TTE results, whether and their age, TAVI, or whether they need a surgical aortic valve replacement, plus minus a cabbage. Okay. What I would suggest is that you read up the echo. It probably won't come out in your exam, won't be asked because the person managing the station will not be a cardiologist, but always sort of keep in the back of your mind, what would you see typically on an echocardiogram if they have severe aortic stenosis, particularly looking at gradients and velocities, and also the sort of width of the aortic valve itself. Okay, next one. 70-year-old woman, short of breath, examine her cardiovascular system. So, bedside, she's comfortable upright. She's got GTN spray on the table. Okay. She has a sternotomy scar. You've looked at her legs. She's got a saphenous vein graft harvest. She's got irregular heartbeat. JVP is raised, and you look at she's got some pitting edema there as well. Okay.
If Galaxy Progress tastes good to you, wouldn't it be great if it did good for others too? By 2030, we commit to help 1 million people, including women, their families, and their communities thrive. Just a little drop of pleasure could create ripples of hope. Galaxy, your pleasure has promise.
This is what you hear when you listen to the chest. Okay. I think that's a bit more obvious. I'll just replay the mitral valve. Is that better? on here. Okay, I do apologize for that, but I think this might not be the best clip, but it's fine. Okay. So I think Shin, you've sort of mentioned above, yeah, possible cabbage and valve replacement as well. Okay, yeah, you're right. So the next thing that can come up in your examination as well are patients who already have had surgery, and you need to, and this sort of pretty much sort of somewhere similar came out in my exam. Either a patient with a prosthetic valve, a tissue prosthetic valve, or a metallic valve. Okay, and what you need to decide is alongside ischemic heart disease, have they had a prosthetic or a metallic? Yep. Opening snap, metallic click. Yep, absolutely. That's correct. You know, they might have mitral regurgitate, severe mitral regurgitation or mitral stenosis that needed fixing. So what you're hearing is a prosthetic mitral click. Yeah. No, opening snap. So you pre-surgery get it with mitral stenosis because you imagine sort of blood flow through a very stenotic valve if you get that opening snap. But yeah, examination, you have to decide, is this prosthetic valve mitral or aortic? That comes up. Yes, post-surgical paravalvular MR, yeah, that can happen. That can happen as well, especially if they've got severe leaks and if they're in heart failure. That's the time I'll speak to a cardiologist. That is bad news. So yeah, you go through the motions, bedside investigations, and obviously, you know, X-rays if they've got crackles in their chest, echoes and ECGs. And yeah, these are the type of patients you probably want to admit. Give them furosemide, restrict them. Yeah, tissue valves. So yeah, not very different to normal heart sounds. You would hear a loud S1 or S2, depending on which valve is replaced. You wouldn't hear a murmur, or you might just hear a bit of residual mild murmur. You technically shouldn't hear a murmur because that means the valve is failing. Yeah, not very different to normal heart sounds. Yeah, you're right. So I think in the last bedside paces that I did, sort of led with the patient. The patient has had a tissue aortic valve replaced, and all you hear was not a murmur, it was just a loud S2. Okay, so patient has had a TAVI, so the murmur's gone. Okay, all you hear is just a loud murmur. Okay, because it is just passing tissue. And also prosthetic material. You hear a murmur, that means I'll be worried that the valve is failing. But these are the patients, what you hear, you know, patients I would sort of get their weight, get a cardiology review. Obviously, if the valve is failing, they need a surgeon to see it. I think we might have time for just one more. So K3, 50-year-old man with dizziness, examine your cardiovascular system. Okay, go for it. What's that? So what signs can you see? Before you throw out any answers, what signs can you see? If one person can come up with the face. Okay, myotonic facie frontal balding, good. Okay, what's the infraclavicular scar? Shona. PPM, yeah, very good. Okay, what is your diagnosis? Yeah, MD, perfect. All right, myotonic dystrophy, very good. So Patients with myotonic dystrophy, you get frontal balding, learning difficulties, diabetes, and yes, the reason why do they have a pacemaker? Yeah, ptosis. Yep, good. Why do these patients have pacemakers? Yeah, conduction disease. These patients tend to develop heart block rather than a tachyarrhythmia needing an ICD. Okay, if they already have a pacemaker and they come in dizzy, okay, always check their pacemaker, okay, to see if it's, and always read the ECG to see if they're actually pacing or not. So, okay, because if they're not pacing, that makes you think, okay, where is the problem? Is there a problem? You know, which part of the pacemaker is not working? Are they undersensing? Is there a problem with the lead? Okay, or is there a problem with the can itself because the battery's gone? Okay, good. Any questions? Yes, target INR range for aortic valve is lower than mitral because mitral, with metallic mitral, the thrombosis rate is higher. So, and obviously it's close to the left atrium as well. So you really don't want clots there. So you tend to sort of aim target INRs of 3.5 in the with metallic mitral valves, and then sort of between 2.5 and 3 for 2.5 and 3 for the metallic aortics. Are we happy with that? So 3.5. So can you repeat inspection slide? What about the inspection slide that needs repeating? Well, is there anything that you're... Yes, so I think, Ali, I think all you need to do is when you go and review, when you do your bedside paces practice, always just look for things like medium sternotomy scars, pacemakers and ICDs. Remember, so subcut ICDs, always look at not just the left, always look at the right and also abdomen. You also want to look for any sternal abnormalities or even spinal abnormalities, and always look for whether the patient has had lines or not. Okay. And then to answer Amit's question, yes, you are allowed to bring your own stethoscope. Yeah, cardiology stethoscope's fine. The stethoscope's not the problem, is whether you know how to use it or not. That's all. Previous recorded teaching, you have to ask Shuaib for that. I'm sure he said that he'll do his best to record this, so fine. Last question. So Fintan, I was just wondering what sort of listeners we use when listening to axilla for murmur of mitral regurg, usual valve area cut off or aortic stenosis. No, so because if you've heard enough severe mitral regurgitations or loud enough moderate to severe mitral regurgitations, the diaphragm will suffice. It is a loud flow murmur. Okay, so you imagine if you look at an echocardiogram and you sort of notice sort of backflow of blood from the ventricle to the atrium because of the mitral regurg. Because it's such high flow, you will hear a loud enough murmur. The diaphragm would have picked it up already. Valve area cut-offs, as you're interested, so normal valve, so for severe, it would be less than 1 centimeter square. For severe, 1 less than 1, 1 to 1.5 for moderate, 1.5 to 2 for mild. Anything above 2 is normal. Order of auscultation, I think I've mentioned this just now already. I always go aortic, pulmonary, tricuspid, mitral. Like what they taught in medical school, that's what I follow. Aortic, pulmonary, tricuspid, mitral. Always remember to palpate the carotid pulse at the same time. MR murmurs. Yeah, no, you're right. Loud enough murmurs can be heard across. Some loud enough aortic stenosis murmurs can be heard at, across the precordium as well, which is why it's always important to put your pulse, palpate the pulse at the carotids to see is it at S1 or S2, and also listen to the carotids as well. If it's severe enough, you will lose the S2. If it's a severe enough, severe aortic stenosis, whereas mitral regurg, you'll hear that that sort of murmur at the apex. That's the time where I would just sort of spend a little bit more time listening to the murmur, and just sit down, good headphones, block out all the other noises, find a good video or sound clip to listen to for aortic stenosis, what a mitral stenosis, what a mitral regurg sounds like, what an aortic regurg sounds like. Okay. Cool. I think let's end it. What videos do you use? I just use YouTube videos. I use YouTube videos to listen, but nothing would beat going to the patient and listen to the murmur. When palpating pulse to see if murmur is S1, S2, does it have to be carotid? I mean, I personally have never felt a subclavian artery pulse before, so carotid is the most accessible one. But yeah, okay. I think let's end it there. Good luck with your exams. Hope to see you at a PACES course. Let's go to the slide. Hang on a second. Don't go just yet. So yeah, like what Shuaib said, click on these QR codes to find PACES courses for the next diet, so you can do a 1-day intensive course or a 4-day comprehensive course. Okay, so yeah, that's it. Have a good Saturday, everyone. I would ask Shuaib to send you feedback forms, so I would really appreciate if everyone can please give me some feedback, constructive feedback, of course. Okay, thank you everyone. Have a good weekend. Bye bye.